It's fantastic seeing so many people face to face again. There's no substitute for that experience in person. The annual meeting is the jewel in the crown of EACTS' educational offering. It's a chance to meet, but it's more than anything a chance to learn, a chance to share, a chance to experience, and be it in the main plenary sessions or in the rooms where people are learning new techniques from leaders in their fields, right through to the really exciting training village and pushing the next generation of surgical leaders. That's one of the most exciting aspects of this few days.
There are different opportunities and different parameters why this meeting is very important for the young surgeons. Of course, we are all looking forward to finally meet face to face, to have a look at the new opportunities in jobs, in education, especially hands-on training. So it is not only about the knowledge that has been transmitted through the internet in the last years through COVID, but especially it's very important for the hands-on courses and to meet the people again.
Today, this is the first simulation session in endoscopic mitral valve surgery that we have during the annual meeting. There are going to be 5 in total, so it is fully booked now. We are giving skills training, working with the long-shafted instruments for the operation for endoscopic mitral. The idea is to make training more accessible for more surgeons anywhere in the world, and the platform that we now have developed is a platform that you can get at your office or at your home. You can assemble it and then you just connect your device, and then you are connected with the course director and you can be guided from distance.
I'm training to be a cardiac surgeon. I'm a resident right now. The endoscopic valve repair tutorial today was great because you almost got a peer-to-peer teaching. You had the opportunity to ask questions at every point of the training, and yes, you just got a great feeling. You could also interact with fellow residents or fellow surgeons and talk about the experiences in each center.
It makes just logical that you train certain skills in a simulation environment and then go to the OR, and that is more efficient, also more safe for the patients. And it's not only for surgeons in training, but also surgeons, senior surgeons who want to start a new program.
I think the future of cardiac surgery very much depends on us, and we are the future of cardiac surgery. And cardiac surgery is at a crossroad with big challenges coming ahead, and we need the brightest and best people who will really refine cardiac surgery further. And EACTS is a very good platform to do that. It offers unique opportunities for education, for training, and for networking. And we need this networking because we need to take those challenges together.
I saw very interesting talks on heart transplantation, and it's super exciting to see what are the limitations in different countries, also the limitations of the organs, the recipients versus the donors, whether it is more important that the heart that I receive is young and from a lean person, or whether it's more important that I myself am lean and I'm young. And it's yeah, pretty interesting and unexpected results also. I really enjoy it so far.
The heart team session tried to define the importance and the idea of the heart team, which is that it is all about the patient, not about the physicians. Our goal is to get the best possible treatment for each individual patient. It's about patient-centered and individualized medicine. It is also about taking out money out of the equation. We talked about the challenges of the heart team, how we organize. We have to prove the benefits of the heart team, so we have to do evaluations and science.
After the pandemic, the knowledge about the type of activity that was going on during these 2 years in the cardiac surgery is really important to understand. We had 2 terrible years, in particular a region that was worse than others. Some hospitals where some program of cardiac surgery were completely stopped. So, of course, we had a big damage in terms of normal activity, and we have damage because the patient that came in hospital when we open are worse than the patient that we have seen before. So there is 2 aspects that are important to know and to understand. The other thing that there is some relationship between COVID disease and the effect on the system of cardiovascular system in the long time. So the long COVID disease is another thing that we have to understand and to know. So the core of this section is actually that, to try to understand better what's happened and understand what it can happen in the next future.
There was one program which was from the vascular domain, which I found is pertinent to cardiac surgery and is very, very, very interesting and well attended, was the aortic dissection session. We had a packed room, experts talking about what do you do with your patient. Should you replace the root? Should you replace the total arch? Often in these meetings we have surgeons going back to their home units and saying, okay, next dissection I'm going to do Tyrone David, full root, full aortic arch, replace all the arch vessels. That's not always the best thing for your patient, and we got some really good data on what we should do, when to do a frozen elephant trunk, and other elements like that. So fantastic program there.
I love coming to the EACTS meeting. It is usually a very, very spicy, robust, lots of discussion. I always learn something. I have great time with my colleagues talking about really detailed cardiac surgery and cardiac surgical techniques. So I find that whenever I come to the EACTS meeting or EACTS meeting, I always learn something, even at my level. So today one of the sessions that I was involved with was the aortic valve repair session. And we discussed all of the different aortic repair techniques, what the results are, some of the controversies involved. There were controversies about rings, there were controversies about whether what we should do in a kind of a mildly dilated aortic root. There were controversies regarding outcomes. So there was a lot of conversation and discussion. So it was an excellent session that brought out a lot of different ideas. And I think people who came to this session will go home and take some of these ideas with them about when they should be doing valve repair, when they should not, what to do with certain different modalities, certain different presentations of the disease process, including patients who may not be valvular repair candidates. Do we do a regular aortic valve on those? Do we do a Ross procedure, which was also spoken about? So it was a very, very excellent session.